All right, good afternoon, everyone. It's Mike Casanassa, and I am the VP of Solutions for Henry Schein. We're going to give it about another maybe 10 to 20 seconds before we actually start. So just hang on there and we'll get started here shortly. All right, good afternoon once again. It's Mike Casanassa. I'm the VP of Solutions with Henry Schein, and I want to welcome you to our webinar today, which is Building and Sustaining an RPM Program at a CHC. First off, thank you for spending the time with us today. I appreciate you joining us. Many of you are already familiar with Henry Schein. We are a very large medical and dental distribution company. We currently service almost every physician practice and dentist around the country, and we're really good at servicing our community health center customers too. We also have a technology division, which is really focused on delivering value beyond supply chain, which is why we're here today. And as a result, I am going to have the pleasure of introducing to you two speakers who are experts in the remote patient monitoring field, specifically as it relates to chronic disease. So we're going to have a chance to hear from Dr. Lucianne Ide, who is the founder and CEO of Remedy, which is a RPM software company. And she's going to walk you through the basics of RPM, and she's going to talk to you about RPM software and what really makes effective software. But more importantly, she's also going to talk to you about other components that you need to think about to deploy in order to make an effective program. We're also joined by a gentleman by the name of Matthew Kozel, who is the VP of Clinical Informatics with TrueCare, which is a CHC. And Matthew is going to talk about how he has used Remedy to really build and sustain an incredibly effective program in the CHC space. So we're going to get to hear about the software side and what makes a great RPM platform, and then we're going to talk about it in a real-world deployment scenario. And hopefully this is going to give you some really good insights into how you can use this information, with your CHC. In full disclosure, I'll share with you that Henry Schein is a minority investor in Remedy, and we spent almost 5 years of doing due diligence, and ultimately we selected Remedy because we believe it is a best of breed, best of class solution in the RPM space. And it's also our belief that when it comes to healthcare delivery, RPM is going to be a transformative solution. You don't see that very often. You don't see many transformational type solutions that come along. But as it relates to really the core patients that community health centers serve, most of those patients with chronic disease, we believe that it's going to be truly transformative. And then on top of that, I think we all recognize on this call that chronic disease is really the true epidemic of our time. Before I turn it over to Dr. Ide, I'll just share one last thing. At the end of this webinar, we'll open it up for questions, and hopefully we'll have some really good dialogue and engagement. We'll also provide you some mechanisms to be able to connect with us. I recognize if you are spending this time with us, you're interested in remote patient monitoring, and regardless of where you are on your journey, whether you're in the early stages of identifying companies that you may want to partner with, whether or not you're in the final stages of actually selecting a partner, or if you've already deployed a platform or program and you're looking for tips on how to make it better, please reach out to us. We would love to give you a further demo of the software that we have. We'd also love to sit down and just simply strategize and share with you, what we've learned over the years. So please take advantage of that. And now what I'd like to do is I'd like to turn it over to Dr. Lucianne Ide, the founder and CEO of Remedy. And once again, thank you for attending our webinar today.
Thanks, Michael. Many of you, thank you for attending. And when you registered, we asked a couple of questions because we find it really interesting to better know our audience when we do these events, and for you to know who are the others who have chosen to join the webinar today. So we asked you a question about insurance coverage for the majority of the patients who you care for, and most of you see patients with a mix of coverage between Medicaid, Medicare, commercial, uninsured. Next slide. And the vast majority of you are, going down this path. You have either implemented remote patient monitoring solutions before or are in the process of exploring those solutions. And that's not a surprise because you chose to join this webinar today to learn more. Next slide. So Remedy is a software and service provider focused around delivering better healthcare solutions and technologies to provider organizations. So we work with organizations across the spectrum of healthcare, including many federally qualified health centers and community health centers. Next slide. And this is our focus, is helping you support patients across that continuum of care. Many of those patients who need that support are people living with chronic health conditions, but doing so in a way that acknowledges the workflow of pressures that your clinicians and teams are under, and that you need technologies and software solutions that deliver efficiency and insights and next steps in care, not just data dashboards. Because you already have a lot of data and that data can be overwhelming. As a clinician myself, I've lived that. And lastly, that I'm sure many of you are under the pressures of staffing, nursing shortages, primary care doctor shortages, and really rethinking what your care teams look like. We see this across the board, right, of coming up with models where everyone's practicing the type of license, and programs like RPM are a great example of that, of how an entire team-based model can help support your highest need patients in a really efficient way. Next slide. So that is our mission. Remedy software is here to enable clinical teams to take care of your highest need patients, both in the clinic and then crossing over into the home and in between. Next slide. The other sort of journey that many folks are on is this journey from fee-for-service care to value-based care. So from 2010 and the Affordable Care Act to a future state of 2030, when Medicare would like for all Medicare recipients to be in accountable care programs, there are some stepping stones along that path that Centers for Medicare and Medicaid have created. These are some examples: chronic care management, remote patient monitoring, and remote therapeutic monitoring, where they are, helping organizations through reimbursement modalities to, learn how to practice in this sort of proactive population health management way. I'll talk in a little bit about some encouraging changes that we're seeing to the physician fee schedule and reimbursement, because we know from working closely in this community health center space that all of these have not been available to FQHCs and rural health clinics. But across the spectrum, we are seeing health care delivery systems sort of work their way through this transition. And I think, as Michael said, this really is the future of healthcare, these hybrid care delivery models, and RPM is an important piece of that. Next slide. So with all of that background and context of sort of who we are, software company that's focused in delivering solutions in this space, remote physiologic monitoring or remote patient monitoring is a pretty broad category of activity that can be applied to any patient with one or more chronic health conditions. And knowing that providers need partners who can help them address multiple chronic conditions, the needs of multiple service lines, Remedy has architected ourselves to have modules for the various chronic health conditions that are most prevalent in the population. And then to be able to support the connected devices that are relevant for that particular use case. So diabetes and continuous glucose monitors and glucometers, hypertension and blood pressure cuffs, et cetera. So we're a really flexible platform. And, some clients, that means we're doing, supporting one program for one disease state, and other clinics, we're supporting multiple programs in multiple disease states across their population. But it provides that flexibility as you're looking for vendors who can be your long-term partner to help grow your program with you. Next slide. So within any of those use cases, right, if you're looking to start with an RPM program for hypertension or diabetes or heart failure, there's some key components to that of sort of how are you going to architect the workflow and how is the technology you select going to best meet that need. So part of it we just talked about, right? Obviously, remote physiologic monitoring, you are remotely monitoring that patient's physiology through a connected medical device at home. But you might also want to know that patient's experience of care, their symptoms through patient-reported outcomes. And it may be really important to you to think about that workflow that I mentioned at the beginning. How are your clinicians and clinical staff reviewing this data, accessing this data as it pertains to their pre-existing workflow and your electronic health record? So Remedy has really made it a priority to bring all of this information into the patient chart in the health record through the way that we interface with health records, because that's where all the context lives for that patient information. If I'm reviewing blood pressure data remotely, I want to know who that patient is. What are their recent labs? What medications are they taking? What other health conditions do they have? So we create this unified view in your electronic health record where you can see the clinical data as well as the RPM data in one problem-oriented and disease-centric view. And that's what the sort of animation on the screen is showing you here, how we merge together the device data with the EHR clinical data. And we'll take that all the way through to the documentation and billing part of that workflow. Next slide. So, again, back to, where you are in this journey. You may have deployed an RPM program within your clinic already, or you may be, trying to learn from the market what others have done and what potential partners have to offer you. And, these RPM really kind of took off in 2019. Remedy's been working in this space for over a decade now, first with many of the accountable care organizations who were focused on these chronic health conditions as part of their value-based care contracts. And then more recently, as that has expanded more broadly into the market and fee-for-service organizations. But that affords us a long history of working with diverse organizations and being able to demonstrate the impact that we've helped them achieve. So whether a Medicare Advantage group like Leon Medical Centers in South Florida, their goal was to get patients with a hemoglobin A1C over 9 into range and have gotten 88% of their patients in the program into range. Boston Medical Center is a safety net hospital in Boston, where we've been helping them support postpartum and now gestational hypertension management. And they had a couple of goals. Patient engagement. They'd tried this with a previous partner and really hadn't been able to get their patients to engage in the program. And so here you see 94% of their patients are taking daily readings, which is really, one of their success measures to identifying moms who are at risk for stroke or another adverse outcome after delivery. And then an example with Northeast Valley Health Corporation and FQHC in California, that's a hypertension use case and helping them get their population from 38% to 70% hypertension control in 6 months. So we really do have the experience and the outcomes to talk about how partners have structured their programs and how we have helped them achieve their goals. Next slide. So sort of covering the clinical areas where we work, mentioning the kinds of devices that we interface to, and sort of the outcomes that we help partners drive. I'm going to come back for a minute here to other things you may be assessing. Workflow, right? If you talk to anyone on your clinical teams, this is such a big part of their life, and what can make their life difficult on a daily basis or not is really helping to streamline the way that they are accessing data. And so Remedy was very early to making a commitment to interoperability with the major EHR partners, including the ones you see here on the screen. We know that Ochin, who works with TrueCare, is the Epic instance that many community health centers and FQHCs use. So that's great to be able to build that interface with Ochin and bring Remedy's technology right into that existing workflow. Next slide. So that's kind of as you're looking at your remote patient monitoring program, you're identifying a clinical condition, you're thinking about how does this interface with my electronic health record. And then you're thinking about what kind of devices do I want to use in my program and give to my patients. Obviously, you're going to select devices that support the specific clinical use case, but there's some other really important considerations as you look at device selection. And I'll say the number one, criteria is ease of use for your patients. Because if you choose a device that's difficult for your patients to use, it then becomes a headache for your clinic, because your clinic will become tech support for your patients. And so, Remedy, through a long history of interfacing with devices, both Bluetooth devices as well as cellular-enabled devices, we have really found that cellular-enabled devices create the least amount of friction possible for your patients. And what that means, if you're not familiar with this kind of technology, is a blood pressure cuff or a scale or a glucometer that has a cellular chip in the device. And all the patient has to do is use the device. So take their blood pressure, step on the scale, test their blood glucose, and the data transmits into our platform and to your clinic. The combination of those really low friction devices with simple technology like text messaging has been one of the keys to our success with clients, is sort of reaching harder to reach populations who they maybe previously hadn't been as successful with engaging, because that's like the common denominator of what people can do, right? They can use the device that you hand them, that you've taught them how to use, step on the scale on a hard surface, sit down, uncross your legs and take your blood pressure. And almost everybody uses text messaging. So that combination has been really successful for many of our clients. We then have some other really interesting and unique devices in our ecosystem, both Dexcom and Libre continuous glucose monitors, CGMs as coverage is increasing with Medicare and other payers, penetration of those devices in the market, expansion from endocrinology to primary care is increasing. So patients who use those devices can choose to share their data via Remedy with your clinic, and that data comes right into your EMR workflow. The same with digital inhalers, where a patient's using a device and an app that goes with that medical device. So we have all sorts of, kind of interesting offerings that depend, we can pair up with a particular use case that you're focused on. Next slide. And so then the question is, what is this experience for patients, right? Do they like it, and is it easy, and how does it change their perception of the care they receive? That graph on the left is a little bit small, but that was a question that we asked participants in an RPM program who were at least 6 months into the program of, does this replace face-to-face care, or is it a supplement to face-to-face care? And the big pink section is that the majority of patients thought that it was a supplement to seeing their provider in person. And some of them thought it could even replace seeing their provider in person, which was interesting. And then on the right, you have, sort of the patient experience of using these devices. Are they easy to use? And you see the vast majority of patients, 91%, said that they were somewhat easy or very easy to use. And I think that's aligned with the data I shared around adherence and engagement in these programs. Next slide. So then the question is, how do you fund, and specifically, how have community health centers, federally qualified health centers, rural health clinics funded getting into the virtualization of care and remote patient monitoring space? Especially during the pandemic, there was a lot of grant money that folks were able to take advantage of. FCC grants, HRSA grants, CDC funds. And that was fantastic because it provided startup funding for a lot of clinics to be able to meet the needs of their highest risk patients, especially the ones who had the most difficult time accessing care, and get a program started. One of the concerns has been, what's the sustainability plan as some of these grants run their course? Next slide. And so, what we would all like to see is that there's sustainable reimbursement around remote physiologic monitoring. And many of you are probably familiar that there are CPT codes for remote physiologic monitoring, shown here on the screen. But the challenge that I mentioned at the beginning is that FQHCs and rural health clinics have not been eligible to bill these codes for Medicare patients. And many state Medicaid plans have followed suit in their policy with, saying that that activity should be covered under the comprehensive fee, and it was not separately billable activity. Next slide. On the other hand, chronic care management is an activity that community health centers have been able to take advantage of. And many of you probably have experience with running CCM programs. Many of our clients jointly run RPM programs and CCM programs on Remedy. So I've been focusing a little bit more on RPM, but we do support RPM, CCM, and RTM, remote therapeutic monitoring, on our platform. So, some of our community health focused organizations use us for CCM and may provide some RPM through grant funding to supplement this. But one thing we're really excited about and encouraged about, on the next slide, please, is the proposal that in 2024, CMS is proposing allowing FQHCs and RHCs to bill for RPM activity under the G0511 code. There's some limitations. The comment period is open on this, so I hope all of you will submit comments. It closes this month, so get those comments in. I know we are. We welcome the progress. We think that there are still areas for improvement, but it really is important progress. We've been advocating for this for years, and we're encouraged that state Medicaid and commercial insurance, both know that they may have different policies, but we're also encouraged that state Medicaid plans may follow suit with CMS once they make this change next year. Next slide. So I'm going to turn it over to Matthew because he is going to share his experience with the program and with how they have built a sustainability model for RPM there at TrueCare.
Great. Well, thank you so much, Dr. Ide. Again, it's a great reminder of all the benefits of partnering with Remedy, as well as probably many of the reasons why we actually chose to partner with your organization. So my name is Matthew Kozel. I am a physician assistant. I've been practicing in family practice for 20 years. I am also the Vice President of Informatics and Analytics here at TrueCare. Next slide. What I plan to go over during today's discussion is, how do we actually set up our RPM program here at TrueCare? What is our process? How do we make it sustainable, or attempting to make it sustainable? What are our lessons learned? And as Dr. Ide had mentioned, we're going to have some time at the end for questions. Next slide. So a little bit about TrueCare. We are a federally qualified health center in the North San Diego region. We see about 300,000 visits in a year, about 60,000 patients we care for. We are all 100% ambulatory, so outpatients. We have 14 locations, 3 mobile clinics. I think we're actually now up to 120 providers. 70% of our patients are Medicaid. So we may be slightly different than some of you, but this is kind of how we are. We have been an Ocean Epic member for 2.5 years. We have been using Remedy for about 6 to 8 months now. Interesting to note, prior to using Remedy, we were involved in a different RPM program called Care Connection Network that used Bluetooth blood pressure monitors. So I'm going to be talking a little bit about the difference between the Bluetooth monitors versus the cell-enabled devices throughout the presentation. Next slide. So I realize that not everyone on this call is from California. So I just want to provide just a little bit of background about California and RPM. Unfortunately, RPM is not a reimbursable service for an FQHC in California. In California, we also only receive 1 PPS reimbursable visit for a medical service and a dental service on the same day. So it doesn't matter if we provide 3 or 4 medical services, we just get 1 reimbursement rate. And also, cell-enabled devices are not something that the providers can prescribe. So we actually have to factor in how do we actually pay for the devices that our patients can use. And we'll talk about how we do that. Next slide. So when we were looking to partner, or actually for a second partner in our RPM journey, these are the criteria that we were looking for. So we had found that at the time, about a year ago, there were many new vendors in the space, and not all of them had a lot of experience, but there was a lot of money in the RPM area. So we wanted somebody who had been in the RPM space for at least 5 years. Given our experience with Bluetooth devices, we wanted to move away from these and actually work on cell-enabled devices. And it was definitely a success, which I'll show in our outcome slide in a few minutes. We wanted a company that provided patient support for the devices. Now, we did this because of all of our difficulties with the Bluetooth devices. As we transitioned to the cell-enabled devices for blood pressure monitoring, most of these issues, in fact, almost all of these issues have gone away, and this actually really has not come into play. So it's an interesting aspect of the technology we chose to use first. We wanted to purchase the blood pressure devices and own them. There are some vendors out there that you actually don't own the blood pressure devices. We wanted to establish a bidirectional interface with our EHR, and we also wanted to design a workflow, have the capability to design a workflow that minimized the headaches of working out of two separate systems. So we've been able to do that with Rimidi. Next slide. So I'm going to talk just a little bit about the different players that we use at our healthcare organization. And our overall philosophy is that once a provider refers a patient to RPM monitoring, we want to take the stress of management off of that provider. So we try not to actually burden the provider with having to make many of the choices, and we use other team members. So generally, our workflow starts off with the provider referring a patient for RPM monitoring. And of note, we've actually at our organization have chosen to target our patients who are of difficult to control. So they've generally been in 3 or 4 times for blood pressure management, and we've not been able to get them controlled. So we send them home with a monitor. So ideally, our provider would have the patient see one of our health educators right while they're in the office. That health educator provides the patient a monitor right then and there and gets them enrolled in the program and teaches them how to use the monitor. It's not a difficult thing. You basically put the cuff on, you push the go button, and it works. So not a lot of education other than making sure you sit down for 2 to 3 minutes before checking your blood pressure. We have a separate team member who actually will monitor all of the blood pressure readings on Rimidi, perform outreach to patients if needed. Rimidi does have texting capabilities built in, which has been quite nice. And then the health coach or health educator who's managing these patients will work with the pharmacist on the next screen to actually work the abnormal readings. So yeah, next slide, please. Uh-oh. There we go. So when our health coach does find patients with persistently elevated blood pressure readings, they actually will have the patient, they will send a message to one of our clinical pharmacists. And it's the clinical pharmacist who will review the patient's chart and actually make medication changes and work with the health educator or health coach to communicate the changes to the patient. So we've chosen to do this so we can allow our primary care providers to continue seeing patients and not have to actually worry about managing their daily patients plus all of the extra patients that would come from remote patient monitoring. And we've actually found, we use clinical pharmacists quite a bit, and our providers are very receptive and basically are just another team member. So we found great success with this. And then, of course, we always keep our primary care providers in the loop about outcomes. So, if or when we've actually achieved control of their blood pressure, or if a patient has been discontinued from the program, we always make sure the primary care provider is kept in the loop. Next slide. So during our pilot, we had about 110 patients in the pilot. At this point, for the last 2 or 3 months, we've been averaging about 100 patients enrolled per month. The great news is 94% of these, if not more, are recording blood pressure readings daily, which is amazing because when we're using the Bluetooth monitors, I think we were thrilled when we got a total of 5 patients over like a year period actually recording blood pressures. They were very cumbersome to use. So obviously much greater adoption by patients by using these cell-enabled devices. 44% of our patients enrolled have achieved blood pressure control. And just as a reminder, we have chosen those difficult to control patients. So 44% is actually really good because we gave it our best shot for several visits, and it took adding RPM monitoring to help do those rapid kind of changes. The interesting thing that we've discovered, we actually have chosen to reuse devices. So a patient gets one for up to 3 months. Once they graduate or discontinue from the program, they're supposed to return that blood pressure cuff to us. We do that to keep our costs down. Interestingly, about 30% of our patients, we never actually get those cuffs back. So it happens. We kind of knew it was going to happen. So we kind of have factored that into our sustainability formula. But it is something that you just need to keep in mind as you're looking to establish an RPM program. And then at this point, we have expanded it to all primary care sites and are working to increase our numbers of patients enrolled at each of those other sites. Next slide. So how do we make this sustainable? So at our organization, as a reminder, we do not get reimbursement for all the RPM CPT codes. So what we have done is we actually have made a calculation, and we realized that we've determined that for every 13 patients enrolled in the Remedy platform per month, we need to have one additional or extra visit with a provider that receives the PPS rate reimbursement, or basically we get a visit for. And this number is based on our current rate. Yours may be different. I think each health center or FQHC may get a different PPS rate. I'll show you the calculation on how we did that. I have an Excel spreadsheet. I also provided that to Remedy as well, if anyone is interested in doing this calculation themselves. But we did not include all of the initial purchases of the blood pressure cuffs. I think we purchased like 200 cuffs to start out with. We use grant funding to do that, so that this calculation of one extra visit per 13 patients does not include the initial purchase of the cuff, as well as the interface. So this is how to sustain it after the initial purchase. All right, next slide. So this is the calculation. I'm not going to go deep into this. This slide deck will be available if anyone wants to do this for themselves. But what we do is we calculate how much does it cost per year for one patient. Our costs are, we have to pay for the platform for 1 year per patient. You have to, in the second year, you actually have to pay for data for that blood pressure cuff. So we include that as part of our calculation. And then we included a 30% replacement of blood pressure cuffs in there. So we got our total cost per 1 year. We divided by that by 12 to get a cost per month. And then we used our average reimbursement using this formula down below to actually calculate how many patients, how many visits do you need, to sustain your program. So this is where we came up with the 13 patients. Okay, next slide. All right, so the flip visit, so like I said, we do have to generate one additional visit for every 13 patients. So we use the concept we call a flip visit. And a flip visit is generally, it's an orchestrated, it's a well orchestrated visit, scripted, that's the word I was looking for, a well-scripted visit, where all of the documentation and most of the work is actually done by a support staff. So a patient comes in, they're actually on the provider schedule. They are a planned double book where we actually have one slot and we actually take a second slot at that same time. So we actually generate an extra visit. And the support staff goes through a whole bunch of questions. We've templated for them using the EHR to gather all of the information. The provider walks in, quickly just reviews the blood pressure. If there's any adjustments that are needed, usually there are not. The provider does that, and that's it. The documentation is done. Provider has a face-to-face visit with the patient, and patient's happy. They get a little time with their provider. We get a visit out of that, and everyone kind of goes on their way happy. Next slide. So what did we learn throughout this journey? first, like I mentioned, the cell-enabled blood pressure monitors are much better than the Bluetooth-enabled devices. So if anyone out there is struggling with Bluetooth-enabled devices, things you have to sync with your smartphone, please strongly consider moving to the cell-enabled blood pressure monitors. We also have discovered that we have to keep track, using any RPM program, we have to keep track of our patients, especially with cell-enabled devices, because we're paying for those. And if we don't disenroll patients, we continue to get charged for those. And then if we lose a blood pressure monitor, we also have to turn off the cell service to that monitor, else we continue having to pay for data in that, each year starting in year 2. It is difficult sometimes to get blood pressure monitors back. We found that we were not doing a good job initially at explaining to patients that they had to return them. So we've not got it all the way down to getting them all back, but we have found some success with making sure we explain it to patients that they have to return them. And then if your insurance or if your payers do not cover cell-enabled devices, you need to build those costs into the budget. Next slide. Also, we've kind of discovered along the way, and kind of how we end up our current workflow, is you really want to minimize the work on the primary care provider. As probably most of yours, our providers are very busy. It is tough to kind of add that one more thing in there. So, having other team members that can take on some of this work is a huge benefit. It is a way to kind of help increase satisfaction while at the same time increasing outcomes on your quality metrics and the control of blood pressure at the patient level. As we've rolled this out to all of the rest of our clinics, we found that we underestimated that the amount of work that some of these team members were already doing. So our coaches can actually carve out time for them to actually work on enrolling patients or monitoring the blood pressure readings. So I think if we had to design this again, we would spend more time on working with each of the managers at the clinics to ensure that there is adequate time in the upfront, rather than kind of figuring this out as we went along. But it happens, no project is perfect, so we are working to kind of correct that. And then the last thing, like Dr. Ide said in her presentation, workflow is everything, right? So you do want to make sure and consider when you establish an interface with your EHR, who is going to do what in what system, right? We have made the choice to try to do everything out of Ocean Epic and only do what's necessary out of the Remedy platform. That made sense for us, but it may not make sense for everyone. The Remedy platform is great. It is well laid out and is amazing, but we felt that all of the communication that happens with all of the various team members, it makes a lot more sense to do that in our EHR, because that's the tool that most people are working. So make sure as you go along the process of using an RPM device and designing your workflows, that you actually consider who's going to work out of what system. And I think that is presentation. All right, so I guess I'm not sure how questions work.
Yeah.
Hey, thank you, Matthew. That was fantastic, and Dr. Ide and Michael for the opening. We do have a couple of questions that were submitted by our guests, so I'll run through the questions and we'll see where we go. So first question, do you have any more information on the Boston Medical Center postpartum hypertension example, a white paper or a report to share?
Sure, absolutely. We've actually done a fair amount of press. If that we're happy to send you information, but if you look up Remedy Boston Medical Center postpartum hypertension, you will find several articles that cite some of the outcomes from that study, or that program, I guess I should call it. Again, remote patient monitoring for postpartum hypertension and gestational hypertension in general is a little bit different than some of your chronic disease RPM, where you might have a focus on avoiding ER visits, avoiding readmission, right? in this circumstance with women who have gestational hypertension, you are trying to identify that woman who you want to bring back to the hospital and readmit before she has an adverse outcome. So that's something that Dr. Yarrington, who's the maternal fetal medicine doctor there at Boston Medical Center, will often highlight, right, that this is avoiding a catastrophic outcome while keeping mom with a newborn baby from having to come back into the clinic for a routine blood pressure check. So we've been, really successful on the engagement side. They have numbers that they have shared around detecting asymptomatic, urgent, hypertension numbers of being able to bring those moms back in. And we've now expanded that to the full gestational population, not just postpartum.
Terrific. And we'll send that out directly as well to the Inquirer, that information. Do you have a link to submit comments to the 2024 proposed physician fee schedule?
Sure. Happy to either put that in the chat here or send that link out.
Great. How long are patients in the program? And what is the cleaning methodology like when trying to give return devices to another patient?
Matthew, do you want to talk about how long on average your patients are in your program?
Sure, of course. The maximum a patient is in our program by design is 3 months. If we in primary care have found that if a patient is involved in an RPM program for more than 3 months, there is likely something else going on, like some sort of secondary hypertension, that the patient needs to have other evaluations done. In typical, a patient is generally in an RPM program for about 6 weeks on average, maybe 8 weeks. We definitely have had patients, graduate after about a month, but generally 6 to 8 weeks.
And then as far as cleaning the devices when they're returned.
Sorry about that.
No worries.
Sure, of course. Yeah. So it is an interesting thing. We've actually, now that we are going into, closer to 8 to 9 months, we're starting to actually have some devices like, wow, this one's coming back with like food stuck on it and stuff like that. So it is an interesting problem, but we typically, we just like any kind of medical, equipment, we often will just kind of use like a bleach solution to kind of wipe it down. If we have kind of extra cuffs if needed. If something is just, that is really horrible, we will just kind of retire it and move on. But the majority of our devices come back kind of clean, in good repair, and just the standard things that you do to your exam room tables and to your devices in the clinic is what we do for our blood pressure monitors.
Yeah,
great.
Hey, real quick, just something to point out, on the fee-for-service side, outside of CHCs, you don't see many folks that actually, refurbish and clean and send back out devices. And I do think that could potentially change depending on how the physician fee schedule changes. And just so everyone's aware, we do have different models in terms of how you can pay for devices, whether or not you want to buy them in bulk or whether or not you want to try to do a subscription model where you pay on a monthly basis. So as things change, we do have a model that can help support those changes and certainly can offer different ways to do it. So I just wanted to mention that because I do think that the changes that are looming could potentially determine how you ultimately build your program moving forward.
Great. How do you get the patients to not go into multiple issues or questions for that double book? What script does staff use to ensure this doesn't happen?
Yes, you're exactly right. That is always the challenge. We tend to just be upfront. It's like, hey, and just our staff say, this is just for a quick visit. We do that when we make the appointment. And we basically just say, hey, we are here right now just to talk about, just to follow up on your blood pressure readings and medications. And generally patients, I do many of these flip visits myself, are quite compliant kind of with that. They're accepting, they understand it. And I think in part because patients know upfront that this is just a quick check-in visit. I think also they're appreciative because we put these, because we want these quick patients in and out, both for us and for them, we put them in front. So they generally, as soon as they check in, we have just like a separate, just kind of it's a little bit, we don't bring them into an exam room. It's a little bit of a different area. So it kind of feels different than a typical office visit as well. So I think that also does help a bit, with that, but we're just kind of upfront, and generally patients are okay with that. On occasion, it always happens, right? There is, one or two patients every now and then where we need to talk about something else. Like we find something else, like, oh yeah, I probably should talk about that chest pain you're having. But that doesn't happen often. So yeah, we're just upfront, and we design a different area for them to sit.
Okay. Are you including the self-pay patients in the RPM model?
Yes. I mean, those are honestly the patients who probably need it the most. There's always kind of disparities of care that happen. We definitely do. So it's just the cost of it's just what you do when you're an FQHC.
Can a PT in an RHC use the G code for both CCM and RPM?
That is out of my area.
Yeah, I'll comment on that, Matthew. So this is one of the comments that we will be supporting, and you submit comments through the Federal Register, and it closes on September 11th. But we'll send out the link. Is that this G code, right? Currently, can only be submitted once a month for a patient, and while the good news is that they are providing a modality to bill for RPM using this code, a limitation that we and others see is that there are other things being billed under the G code, and there's going to create conflict of choosing, what am I going to deliver to this patient this month if I can only deliver. So that's a limitation that we're going to comment on, and that I think others are as well.
Is the duration required for graduation, or is more focused on sustained BP readings?
Can you repeat that question?
Yeah, it came in as, is the duration required for graduation, or is more focused on sustained BP reading?
I see, yeah. So we generally, in our program, we aim to have patients with a sustained blood pressure for 2 weeks that is controlled. Once they've kind of had the majority of their blood pressure readings controlled for 2 weeks is when we decide to graduate a patient. So it's not really based on any time, it's more based on, sustaining blood pressure control.
Great. How often do they validate or calibrate the devices since they are in the patient's homes?
Dr. Ide, I'm not aware of any need to do that.
No, I mean, these are, FDA cleared medical devices. There's an organization called validatebp.org that you can go to their website. We only use devices that are approved by that organization because there is concern around home ambulatory blood pressure monitoring and the quality. And so all of these devices have to meet that extra level of quality testing through Validate BP in addition to the FDA.
Yeah, and let me just comment on that too, because I do think when you're looking at an RPM company, right, the devices, the software is critical, the devices are critical, and also whether or not you're going to do the monitoring or potentially outsource it. But with the devices, just to point this out, there are major differences between what devices are deployed, and if the devices seem cheap and they're knockoff brands or maybe not known and sourced from overseas, just that is a absolute red flag. Devices aren't cheap, and you get what you pay for, and at the end of the day, that leads back to accuracy and then overall compliance and success. So generally speaking, the devices that should be deployed in an RPM, in an RPM program should be industrial grade and should be pretty robust. So just be aware of that. If you see cheap devices and that's what they're touting, then it's very likely you're going to have more problems than it makes the program worthwhile.
Yeah.
Let's see. Could you discuss other use cases for RPM, specifically diabetes and obesity?
Sure. So, diabetes is a great one. It's actually where our company started over 10 years ago. And I say it's a great use case because self-monitoring is not new to diabetes and is part of the standard of care for patients with diabetes. So many organizations are, focus some of their RPM initiatives in that area. And whether that's connecting to glucometers or connecting to continuous glucose monitors. We also connect to some of the insulin pens that are tracking adherence. And, as far as program design, it can be a nice overlay where there may be quality measures that you're trying to impact as it relates to your payer contracts. Or other reporting that maybe you have to do to the state, and that can make for a really nice synergy with an RPM program to say, we're going to take our patients with a hemoglobin A1C over 9, who, and in addition to anybody with a recent admission, in addition to anybody with more than one ER visit. So we often work with providers to sort of, design the program from, who are you going to focus on? And then you may have other programs around diabetes education in place that this can also dovetail with nicely. On the topic of obesity, and there's certainly some overlap here with diabetes, with the GLP-1s and some of the new drugs that are on the market, right? Another area of great interest at the moment with Ozempic and Wegovy and all of these, where again, RPM clinically can be a really important part of supporting and monitoring weight loss in those patients, not just with the scale, but say you have a patient with diabetes who is enrolling in a weight management program and they're insulin treated and their insulin needs may change as they lose weight. And so being able to remotely monitor them and remotely adjust therapeutics, all of those things can be really synergistic with running an RPM program.
Okay. Aside from purchasing devices, what is the pricing model for the Rimidi platform? Is there a global charge for use, or is it based on number of patients or accounts?
It is based on both. So, smaller organizations often want to start a program with kind of a per patient per month pricing model. So as we mentioned, you can buy devices up front, or you can pay monthly for the device and pay monthly for the software. And if you need outsourced clinical support, you can pay monthly for that as well. To sort of align, the cost of the program with, your growth. And then we have enterprise pricing models as programs, grow and get established, where you can pay a flat fee monthly for the software and really allow you to scale the program.
Yeah, and Dr. Ide, there was another question regarding outsourced or third-party monitoring, which Rimidi does offer. I just wanted to be clear on that.
Right, thank you. So not, with the staffing challenges that everybody's having across every provider, delivery system today, nursing and otherwise, we find that a lot of organizations would like to start an RPM program, but they don't have the current staff and they don't feel like they can hire the additional staff. And so we will provide the monitoring to them and then design the protocol with them of when care will be escalated back to the provider. And Matthew mentioned sort of their escalation internally, right, to a clinical pharmacist team who could make medication adjustments. So, that's kind of an internal example of what we're talking about, that if our outsourced nursing team is doing the monitoring and that patient needs a therapeutic adjustment, contacting the practice who would make that kind of adjustment.
Okay. What is the average age of patients that you have on this program?
Across our clients, and even just across FQHCs and CHCs, it varies by their population mostly, right? So everybody thinks of the Medicare population and they have difficulty accessing care. Maybe they don't have transportation, but we see a lot of sort of, working age people as well who have a very hard time getting off of work to get to a medical appointment. And therefore that might be the higher need, higher risk population that's having difficulty controlling their blood pressure or their diabetes. So it really does, and obviously our programs around gestational diabetes or hypertension are a much younger population. So it really works across the spectrum. It just looks a bit different depending who your population is.
Can you have this
I'd just like to add to that.
Go ahead, Matthew.
So sorry about that. Yeah, I think Dr. Ide, you're exactly right. You know, in my mind, I would think it'd be like in the 60s and 70s, but we actually tend to find that it's more the 50s and 60-year-olds. You know, that's our bigger group at our healthcare organization, but it is, you know, we, as an FQHC, we have patients who it is difficult to get off of work. It is difficult with transportation, and it is such a nice option to be able to provide them with a monitor and actually some follow-up. So.
Great, thank you. Can you have this RPM program without one of the listed EHR programs?
Yeah, absolutely. We run as a standalone software platform for some clients, as well as integrated to their EHR. So absolutely, we can do either of those.
Okay. How did you come up? Sorry, go ahead, Matthew.
Sorry. Yeah, of course. When we started ours, we actually started without any EHR integration because we wanted to get it up fast. And I honestly, like having the EHR integration is like icing on the cake, but the majority of the benefits comes in with actually just getting the devices into the patient's hands and the readings back into the Remedy platform. So yeah, I honestly, we would be completely fine if we never did EHR integration, but it is nice, of course, if you can.
Great. How did you come up with 2 weeks as a norm? It seems a lot of work to keep your patients coming and going every 2 weeks. What are the qualifications patients have to get this program?
So for 2 weeks, coming and going, there really is no coming and going because they're just monitoring in their home. These are home-based blood pressure readings. So once the patient has a home blood pressure reading or wherever they're checking it at, right, for 2 weeks, we discontinue it. We don't actually have the patient come in and do a final blood pressure reading in our office. I think we find that most patients, I think it's in the 90s, are checking upper 90s are checking it daily. We actually sometimes find more difficulty in getting the patients to stop. They like being able to do this, which I guess is a good problem. And I'm sorry, what was the second part of the question?
What are the qualifications that a patient needs to have to put them on the RPM program?
Sure. And I think this is up to each of the health centers to decide on their own. And I think it's kind of a factor of, the costs and the staff that you have to kind of monitor. At our organization, we have chosen the difficult to control patients with hypertension. So patients who have had 3 visits with a provider, sometimes even 2 visits, where we have not been able to adequately control their blood pressure. So that's generally our criteria. They have to have been diagnosed with hypertension, and we've tried a bit to control it with standard ways. And then, we provide them a monitor.
Okay. Can patients be on RPM for more than 90 days? How do you keep the patients to be compliant with device usage?
I mean, from a fee-for-service RPM point of view, they certainly can be on RPM for more than 90 days. And we have certainly seen the experience Matthew referenced of the conversation often goes to how do you get people to engage? There's a separate conversation if patients really like this, and if you want to graduate them, you may have patients who don't want to be graduated from a program. So because they like the support, and we're happy to talk to you about approaches to that. From the engagement point of view, though, we have a whole, client success team and clinical optimization and best practices that we share because our experience is the secret to engagement is the initial engagement, right? When you onboard them to the program, those first 30 days really matter. And building the habit of using the device, which you can support through the positive as well as negative feedback, but the delight of a patient and the surprise the first time they get a communication from you in response to their reading at home, which is a very different experience from all of us who were used to having to call our doctor and leave a message or send a portal message to try to get some attention. It becomes this really virtuous feedback cycle.
Okay. Hey, Justin, it looks like we're right at the mark. So I think we're going to go ahead and just do a quick closing. First and foremost, if you have questions in that we did not answer, we will reach out to you individually. So we'll provide you a customized response. So we'll take that on to connect with you. For anyone else, if you would like to connect with us as we send out the follow-on materials, there'll be a number of ways that you can engage with us, and we hope that you do. We think that we can give you some really good guidance, and I can tell by the super insightful questions that we received that hopefully this was incredibly well received by you all. So with that being said, I want to thank Matthew, first off, for participating and giving his time, and of course, Dr. Lucianne Ide. And for the rest of you, especially the participants and attendees, I want to wish you a great rest of the day, and thank you for attending. Enjoy.
Thank you.